My algorithm for working at patients with abnormal uterine bleeding would consist of a thorough detailed history and physical examination, a lot of times laboratories to go along with that to determine if there was any hormonal imbalance that might be leading to her abnormal uterine bleeding, and then a detailed physical exam and a targeted physical exam in these patients. Depending on what those findings or what my exam and labs yielded, we would then proceed a lot of times with a transvaginal ultrasound. With intracavitary pathology, if we saw something on ultrasound that demonstrated possibility of something in the uterus, whether it be a thickened endometrium or something that looked polypoid or fibroid, we would proceed with a saline sonogram at the same time. At that point, if there was pathology that needed to be removed, and this was felt to be the culprit of the patient's bleeding, we would set them up for an outpatient saline hysteroscopy, DNC, or operative hysteroscopy in that case. Since acquiring Endosee, the pathway for diagnosing and working at patients with abnormal bleeding has changed in that we look a lot sooner than we used to, or I look a lot sooner than I used to. The same initial evaluation with a history and physical would still occur. Laboratory evaluation, if indicated, would then be obtained. And the patients, sometimes even the same day, if they're coming in for this problem, would have an ultrasound, sometimes the same visit. Using the Endosee technology, it's completely changed how we can evaluate the endometrial cavity. No longer does this have to be done as an outpatient in a surgery center or a hospital. It can be done the same day in a very easy way in the office, not really interrupting our office flow and not requiring a lot of setup, and very easy and comfortable for our patients. So after I take a look inside, if I see global pathology, I would then proceed with an endometrial biopsy. If there's something focal that's going to be removed operatively anyway, I'll forego the biopsy, turn around, show the patient exactly what I've seen, and proceed with boarding them for an outpatient procedure. This procedure seldom takes longer than probably 3 to 5 minutes to perform, and the endometrial biopsy takes an extra 30-40 seconds afterwards. So it really doesn't add that much to the patient's overall visit, and we get two things done at the same time. We get a visualization of the cavity and a biopsy.